I'm going to demonstrate how the enhanced heart failure service protocol works within the consultation. So here we are within the patient record. When I start to record the consultation, we see that the protocol triggers automatically and asks me if this is what I want to do. Of course, I could be consulting the patient for other issues, but on this occasion we say we're working for their heart failure. So I accept that I want to use the protocol. The first thing it asks me to do is what am I doing at the moment? Do I need to record an ECG? Do I need to manage the patient? And I'm going to manage the patient on this occasion. The protocol's first step is to look for ACE inhibitors and for ARBs. It's found that the patient is currently taking an ACE inhibitor, but now wants me to check that the medication is appropriately up-titrated. So I say, yes, I wish to check that, and it takes me to the prescription screen so I can see what medication is being prescribed and what doses the patient is receiving. I know in this chap's case, he's on the maximum tolerated dose, and it's asking me if I would wish to code that so that in future episodes I'm not going to be asked the same question. The enhanced heart failure audit assists a clinician in managing the population seen in general practice by highlighting those patients who are yet to have their medication optimised, not only at the level of just an ACE inhibitor, but to triple therapy to ensure that their heart failure progression is prevented as much as possible. The enhanced heart failure clinical audit also identifies patients who have yet to be coded with a heart failure diagnosis. Now, these are important to the GPs on two levels. First, there is the clinical level to suggest that a patient who is yet to be coded and identified cannot be appropriately managed. The clinical system will not trigger automatically to demonstrate this patient to the GP and the clinical team to allow them to ensure the medicines are optimised. However, on a second level, also important to general practice, is that if our QOF populations aren't appropriately populated, then we will receive less funding per point. So it's quite important that not only do we try to identify patients for their good clinical care, but it also ensures of good clinical management of the general practice budget. The clinical audit identifies patients who are on various levels of intervention. So it shows those patients on ACE inhibitors, rate control medication, or aldosterone antagonists. But more importantly, it shows how they are being used in combination. So it can end up with that list of patients who are most optimised on triple therapy, and also identify those patients who may not be receiving any of the three vital interventions. Increasingly, GPs are being asked to see not only our population as individuals, but as a population of patients with a clinical condition. We can use the audit results generated by Oberoi to show us who is at risk within our general population, to develop task lists, to call patients forward to ensure that their blood pressure is optimised, they're on ACE inhibitors and that is optimised, and their heart rate is controlled also. In this way, the audit and the protocol can be used in conjunction without the patient present to make sure that the clear steps needed to be undertaken are outlined to the GP through administrative work rather than clinical consultation. The enhanced heart failure audit is stored within the System 1 environment and can be found in the normal reporting folders. So into reporting, clinical reporting, and there is the file labelled Oberoi with all the various components outlined so you can see the actual details of the paper audit within the clinical system. And as we know from our reporting within System 1, from this stage you can access the patient lists to ensure that people can be managed en masse, either through lettering, inviting people to attend, or with ensuring the appropriate codes are put in their notes.